Okay, so let's go through a quick shoulder evaluation. So first thing we want to look at is observing the shoulder. I'm looking mainly for any obvious things, so lumps, bumps, bruising, change in colour, change in if there's any sweating around there. So basically just having a look at the normal stuff. Are the bones and the positions of the shoulder relatively normal? We can look generally at the neck position, we can look at the back, we can look at the muscles. So is there any atrophy of muscles? Again, that might indicate nerve pathology, or it might indicate just some weakness through there. So we're looking at shoulder blade, any winging, any major positional changes, height of the trap. So general height, I don't get too obsessed with shoulder height because there's no clinical research that shows it's ridiculously relevant for lots of things, but you just want to get a general idea of what we're dealing with. And then again, looking at the shoulder from the side. So if we turn to the side now, Shah, same thing. So just looking really at muscle bulk, looking around the deltoid tuberosity through here, looking through the upper shoulder. Again, looking at the position of the shoulder relative to the thorax in terms of whether it's forwards, whether it's backwards, just getting a general idea. And so that's the first thing we want to do. The second thing we want to do is go through our range of movement stuff. So first of all, Shah, if we go thumbs facing forwards, and then I want you to lift your arm all the way up to the ceiling as high as you can go. And we're just going to see, has that person got full flexion of the shoulder? I then can add a little bit of overpressure. Obviously with these things, and back down again, I'm going to be asking the patient whether they feel any pain or symptoms as they're doing that. Normally what I do is ask a patient to start with, do you have any pain or symptoms at the moment before we do anything right now today? And see what they say. If they say no, that's fine, cool. When we do these movements, tell me if you feel anything different as you do the movement. And that way they're going to tell you whether there's anything different. Sometimes they will have pain at rest. So what you're really after there is more, does that pain change? Not just if they've got pain, because if they've got pain at rest, you do these movements and they say, yes, I've got pain, well, they've got pain anyway. So is it something that's different or more aggravated as they do these movements? The second one would be abduction. So we're going to go thumb to the side. So we're getting the patients to go thumb out to the side and then just out to the side all the way up to the top again, Shah, for me. So we're just going to have a look at that abduction again, just looking at the movement, looking at range, looking at whether there's any pain, looking at control of the movement. Next thing we're going to go is hand behind the back. So if we go thumb behind the spine, Shah, for me. So you go, yep, and then up the spine as high as you feel able to go. And then back round again. And I would always do this and obviously do this both sides. So both flexion, abduction and hand behind the back. Flexion, abduction we do at the same time. So both hands at the same time. This one we would do one and then the other, and we would compare sides basically. Then lateral rotation. So if we can bring you around facing forwards with this shot and just have the hands like this. And then what we're going to do is keep your elbows tucked to your side and we're going to rotate outwards to the side as far as you can go. So then we've got our lateral rotation and then back in again. So very, very simple. Now, in this standing position, what you can then do is look very quickly at some isometrics for shoulder. So whilst they're in this position, I can now normally I would do this both sides, but for the purpose of the video, I'm going to do it one side so it's easier to see. So just relax this arm for me, Sean. What I want you to do is make a fist, okay? I want you to just hold it there and don't let me push you down. So holding it there, good. Hold it there and don't let me bring you up. So we're just looking at biceps and triceps. Then we can look at internal and external rotation. So hold the hand there, don't let me push you in. Or push you out, sorry. And then hold there, don't let me push you in. And then we're looking at lateral rotation with that one. So very quickly, we're just looking at isometric movements to see whether there's any pain. Now, I could easily do those movements in different ranges as well. So I could bring it out to here, and I could ask to hold there and don't let me push you down. Good, and then relax. So very quickly, just get an idea of strength. Now, I also like to do some of the shoulder testing, special testing in standing while they're there, because I just think it's easy and quick to do. So I can do a very quick Hawkins-Kennedy test, so nice and relaxed. I'm just going to bring you down this way. And again, just asking for whether there's pain or symptoms doing this. With impingement, you'd expect it to be yes. If we go empty can test, so thumb towards the ground, Shah, for me. Hold there and don't let me push you down. Good, and relax. Then what I can do is just ask, hold the hand here and say, Shah, can you hold that? Don't let it drop. So I'm looking for a drop test for rotator cuff tears. So with those two tests there, I've kind of covered impingement. I've also covered rotator cuff tears. I can then also do a supinated hold there, don't let me push you down. It's good. And then I compare that to the empty can test. Again, we'd expect with impingement typically for thumb down position to be a little bit worse. Also with that push down, I can bring the arm more here, slightly 45-degree angle, hold there, don't let me push you down, so I can do a speeds test. And again, I would do these, generally speaking, both sides at the same time. The ones I can't do because I'm controlling the arm, I would obviously do one side and then do the other side. So we've kind of done Hawkins-Kennedy, we've done empty can test. We can also do in this position a very quick, hold the hand there, Shah, don't let me push you forwards. External rotation in 90 degrees position test. I could also do a more of a slap tear test, so hold there, Shah, don't let me move your hand outwards towards me. That's good. So then we're doing that, loading the bicep, which is going to be indicative of slap tears or bicep tears. I could also, nice and relaxed by your side, do an instability test in standing. And again, I'm doing these in standing, but you could quite easily do these in lying if you want to, but I think often it's just quicker if you do everything you can in standing and then you get the patient lying down. So again, I can control through the shoulder, control around the humerus, do a inferior drag, so I'm basically pulling downwards, looking for the sulcus sign, so looking for that gap in the shoulder. Is there anything there? I can then do a bit of a load and shift, so I can grab the around the scapula with one hand to support, and then around the head of the humerus, and just looking for how much movement there is in that side. Again, people can get bogged down with, okay, is it a third forwards, is it 2/3, like how much am I doing? I think often when you've got someone with true instability, you're basically going to feel that. Like it's not going to be a very subtle thing. It's going to be very obvious. And you've obviously got your history that you're going with a lot of this stuff. You're basing what your tests you're doing. So I wouldn't necessarily do all these tests with every patient. It would be a case of a case by case, picking the test that I wanted to use based on A, their history, B, what their range of motion tests were like. So you're always going to be assessing and judging your assessment or objective assessment as you go through. It's not like you just do every single test under the sun, because obviously you haven't got time for that. So you're trying to pick your tests based on the history, based on the range of movement, and based on how some of the other tests go. But again, with that little battery there, we've done quite a lot of tests for impingement. We've done instability, we've done slap tears, we've done rotator cuff tear. The other test in this position that what I can do is a hand behind the back test for the rotator cuff. So if you then, Shah, push your hand away from your back, hold there and don't let me push you forwards. It's good. And then relax. Good. So that's a good test for the strength of the subscapularis. Then if we turn all the way around, Shah, facing towards the camera, and then arm at the side, and then make a fist. And our classic infraspinatus test would just be coming out slightly to the side, and then just hold there, Shah, for me, and don't let me push you in. So it's an external rotation against resistance, and then relax. And then seeing whether that was painful or weak, and that would be indicative of an infraspinatus or a rotator cuff pathology. Also, AC joint issues can be tested really quickly. So again, number one, just palpate the AC joint. So I'm just going to palpate through that AC joint with my thumb. One side, other side, does it feel different? Scarf test is a useful one for this as well. So we're going to bring your arm up, Shah, keep your arm nice and straight, and we're going to come across your body. So what we would expect with this would be, again, pain specifically around the AC joint. And the other one would be a resisted adduction test. So hold the arm there, Shah, don't let me move you. Or a resisted abduction test in this position. Good, and relax. So again, that would be pain around the AC joint would be indicative of that test being positive. If you had a scarf test that was positive, that test that was positive, and it was painful around the palpation point, and you had a history indicative of that condition, then very likely to be ACJ. So again, with those tests, we've done AC joint, rotator cuff tears, rotator cuff impingement, slap tears, instability of the shoulder. And then what we would do then is move on to more of our lying down tests. Okay, so shoulder palpation wise, really there's a few areas we want to look for. So first of all, palpating kind of anteriorly and superiorly. We want to look at slightly lateral as well on the humeral head for that rotator cuff tendon. So you can feel with your thumb around that point for that rotator cuff tendon. We can feel down into the deltoid tuberosity as well, so down more laterally in the arm to where the deltoid attaches. Okay. The other thing we can feel around here is the AC joint, so again, good to palpate that for AC joint conditions. So we're just coming across the clavicle to the end, and then we've got our AC joint at the end there. You can also feel into those upper traps in this position, so again, more into this area here. So I'm palpating through here with my hand, just to see if there's any tension through upper traps, down through first rib as well, so I can palpate through to first rib through here. We can look at just pecs where they come in and attach to the shoulder, and then just clavicle, so the collarbone in general to the sternum. Also the coracoid process, so if we come through here, we'll be able to feel and palpate that coracoid process, which again is more important for things like your frozen shoulders and things of that nature. And then we would get, we can palpate around the back of the shoulder as well, so just into the posterior cuff, so around the back of the shoulder here. So again, what we can then look at as well would just be the muscles in the back of the shoulder. So we can palpate through the sort of infraspinatus or infraspinous fossa, where infraspinatus sits, the supraspinous fossa, where supraspinatus sits through here. We can palpate down through rhomboids in the thoracic spine. I'd also palpate through the thoracic spine or through the spine itself, and through the paraspinals. So again, paraspinals and rhomboids on that side, just to see whether there's any stiffness through that thoracic spine on that side as well. Again, you can then palpate down the border of the scapula, and again around the scapula. So just palpating through the soft tissues, just seeing how it feels. Are there any kind of points of particular tenderness? Is there any stiffness in the spine that could be contributing to a shoulder pathology? The other thing we can do with the shoulder is a few accessory motions. So we can look at things like a bit of a AP glide through the shoulder. So we're just creating that anterior to posterior force and pressure through there. We can also pull into more of a PA position, so just by holding around the humeral head. So we're just trying to glide that humerus in the joint and just compare from one side to the other. Again, I think that there are probably is probably too much emphasis placed on this as being a massive factor. We know there's massive variations in patients, there's variations in how much a therapist will actually push in terms of pressure. So whether you need to put much weight in this in the assessment, I'm not convinced, but I'd still do it and compare it to the other side. Also, you can see whether someone's got pain. Often, if they've got rotator cuff pathologies, you may find that the thumb is sore at the front because basically that rotator cuff tendon is a bit sore at the front. But it's something that you can test, and I often do with shoulder pain patients. The other thing in this position is that it's more of a classic instability test position. So if you get someone into this position, you're looking at like a instability test of an apprehension test. So again, I'll just ask her to just relax. I would be asking her, as I let the arm relax down, does it feel like it's going to give way? Does it feel like it's okay, or does it feel like unstable? And then what I would do is put a little bit of an AP force. So with this hand here, I'm putting a little bit of pressure through, and I'm asking then, does it feel better? If it's unstable, then it should feel better like that. If I then let go, it should feel less unstable. Now again, people have talked about whether you should really even be doing this test if something's really truly unstable, and actually you don't want to do that. If I was getting to here and someone was sort of saying it really doesn't feel very good and feels unstable, I wouldn't be pushing it further than that, and I'd probably just do a light AP glide. Does it feel better? Yes, it feels better. Okay, I'd then bring the hand away from that position before I then let go, because I don't want to put it in a really, really vulnerable position. So again, in this position, your slap tear test, so you ask the patient to hold there and don't let me bring you away from the body. Sit and then relax. So again, for a biceps load test, that's going to be positive. Okay, so in this position, I can also do a quick neurological test. So the first thing we can do is a bit of a sensation test. So I'm just going to use a bit of the couch roll for this. Obviously, with certain conditions, I would also do sharp or blunt, and I would also do hot or cold, but for this purposes, I'm just going to use this, and then you can home in on that. So again, I'm just going to ask Shah to close your eyes for me, and then just tell me if it feels the same on this side and this side.
Yes.
Does it feel the same on this side and this side?
Yeah.
Same on this side and this side?
Yeah.
Same on this side and this side?
Yeah.
Same on this side and this side?
Yes.
Yeah, so I'll just go through our dermatomes with this. I'd be looking at whether it feels the same. If it was different, I can hone in on that and kind of move around a little bit more. But that's to be done as you find with a patient. Next thing I can do is quick myotomes. So Shah, if you shrug up towards you, hold there, don't let me push you down. Good, and relax. And if we bring your head slightly to this side, can you hold there and don't let me push you back across to the middle? Good, and then back to the middle. Over to the other side, hold there, don't let me push you back across to the other side. Good. So I'm doing side flexion of the head, I'm doing shrugging of the shoulders. Then if we go arms bent to this position, move slightly to the side, can you hold there, don't let me push you in. So abduction of the arms, then hold there, don't let me bring your hands down. That's good, good. So bicep, so extension of or flexion of the elbow, then extension, so don't let me move you this way, good. Then if we go there, hands like this for me. So then I'm going to say, hold your fingers apart, don't let me move them in together. I'm just seeing whether the fingers can move closer together. Perfect. Then if we go hands, fingers together, and then just little finger out to the side for me and hold there and don't let me push you across. So this would be more indicative of our ulnar nerve issues. Good. And then, yeah. So I'm just generally looking at myotomes in the upper body. Then we can just do some reflex testing. So just nice and relaxed with the arm. Putting my thumb over the bicep tendon, and I'm just looking for that jerk of the tendon by striking my thumb when it's over the tendon. Then I can come into brachioradialis, again looking for that same thing, pronative reflex. So I'm just hitting my thumb and looking for that reflex. And then you can rip around the fingers again and just looking for that grip reflex. The main one that I'd be working with really with this is that one through biceps. But again, you can do your full gambit of reflex testing. And with your reflexes, your myotomes and your sensation testing, that's kind of going through the frank neurology of an upper limb condition. What you could also do is our upper limb tension tests. So what I'll do is grab the hand and control that hand position nice and relaxed, just let it go. And then I'm going to control the shoulder as well. So I've got abduction of the shoulder with a little bit of depression through the shoulder. I'm going to come into full external rotation, full extension of the wrist, and then full supination. And I'm going to then extend the elbow and just ask the patient to let me know when they get to their limit. It's going to be quite stretchy for everyone towards the end, but you just be looking at one side versus the other, and also whether it feels particularly painful, obviously, if there's if you feel like there's a neural tension component. So that's our median nerve. Radial nerve, what we would do is go thumb in between the fingers, and then we would grip lightly around the thumb. Then we're going to bring the arm down. We're going to rotate the arm internally and flex the wrist. So again, normally I would do this stood in this position, but I'm going to do this in a slightly different position for purposes of the video. And what we're going to do is, again, cause that depression through the shoulder, and we're going to then abduct the arm with the arm staying straight. And what you'd be looking for is that tension through the forearm, which will be stretchy, but we want to know whether there's any particular pain or stretch doing that. And then the ulnar nerve, we would just simply relax the arm into a bent position. This one's usually the most comfortable for patients. Control the hand position, so bringing the hand rotated round in this manner. And then we're going to basically keep the arm here, and we're going to move the arm up towards the ear in this fashion. So basically you're bringing the back of the palm into the ear, and we're asking again if there's any stretch or tension doing that. What you can then do with all of these neural tests is, whilst the neural test is on, so I would come up into that stretch position, and then I would say to Shah, can you bring your left ear towards your left shoulder, so you're side bending your head to the left, and then back to the middle. and then we'd be asking whether it feels more stretchy or different when they do that. If it was, then it would suggest that there is some sort of neural or neck component to the condition. So with functional testing of the shoulder, this 4-point kneeling position is a good one to do. So what I can ask Shah to do is, A, can she do like a push-up plus? So can you push away from the plinth for me? Good. So just looking at serratus anterior. Then what we can ask her to do is, can you keep your head in a nice neutral position? So relax through here, arms nice and straight, but tuck the chin in for me, but keep your head against my hand. So like, yeah, like that, perfect. Now, in this position, can you lift one hand up towards the ceiling for me? That's good. And then back down again, and then lift the other hand up towards the ceiling. So again, what I'm looking at with this is deep neck flexor in terms of the head, but also the stability through the shoulders. Can she stabilize well on one arm as she lifts the other arm? You could quite easily do this with one arm and one leg lift as well. So you've got really looking at stability through there in a pushing type fashion. The other thing we could ask Shah to do is simply some kneeling press ups. So if you come into a kneeling position a little bit further back with your knees, that's it. And then can you do a press up for me? That's perfect, yep. And just do it again. Spot on, perfect. And then relax, just, yeah, come back into normal position, perfect. So again, just looking at strength, we're looking at whether it's painful, we're looking at the stability through the shoulder blades as Shah does that. And again, that would be a good way to look at just functional strength through the scapula. You could also look at a push-up test against the wall as well, so single arm push-up test or any push-up test against the wall is a really nice one for shoulders. So hopefully that's a really good objective assessment, very quick shoulder assessment that you can do. Obviously there's much more complexities, but this gives you a really good grounding for what you would do in a shoulder assessment. There are specific tests that you can use. I've done a really extensive course on musculoskeletal assessment, which you can check out in the description below. And that's called the Musculoskeletal Masterclass. And that's got every special test you would need for the shoulder. It goes to not just the shoulder, but basically the whole musculoskeletal assessment of the entire body, neck, shoulders, knees, hips, lower back, everything, in terms of making you much more confident with your diagnosis. So check that out in the link below. If you've got any comments on other things that you really like in your shoulder assessments that you use, any specific special tests or ways to do things, whack that in the comments as well, because I want to make this as a most interactive learning environment on YouTube where people help each other, we help each other get better. I can then produce other videos about shoulder assessment with other things in that you guys use. So don't feel afraid to comment and let me know what you guys do as well. If you enjoyed the video and you found it helpful, then please do subscribe and like the video. It really does help the channel out. And if you want to get better at shoulder diagnosis, I've done a full video on every shoulder special test that you can do, and you can check out that video by clicking on the video here.